Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations and give us any ideas in regards to future topics or future speakers. Actually, our speaker today had such glowing reviews from her last presentation that at the subsequent CME committee meeting, we saw lots of comments asking her to come back, and she kindly has accepted our invitation to come back. Today, it's my pleasure to introduce Dr. Amal Rahhal. She is Assistant Dean for Student Affairs and Curriculum at the University of Iowa, and she's also the Program Director for the Endocrinology Fellowship Program there. And she is Professor of Medicine in the Department of Endocrinology and Metabolism. And she has, as I mentioned, kindly accepted and braved the inclement weather to drive over from Iowa City and update us on osteoporosis today. So please join me in welcoming Dr. Rahhal.
Thank you. Thank you. It's my pleasure and an honor to be invited back to lecture to you guys. Teaching and giving talks is like really one of my hobbies. It's kind of the running joke at the university is that no one asks me to give a talk, and I hardly ever say no because I really love this way of transferring knowledge among others. So I'll talk to you about osteoporosis, which is my little clinical niche. I titled my talk of fractures and drugs, so which means I'm going to talk a little bit about osteoporotic fractures and a little bit about osteoporosis drugs, practical issues in osteoporosis therapy. I have no disclosures of interest to this talk. My objectives is we're going to use a patient, and this is actually a real patient from my clinic that taught me a lot about this topic. So I'll take you on a journey with this patient, and during that I will try to illustrate some key concepts. Hopefully by the end of this session you'll be able to define the relationship between osteoporosis and low trauma fractures, determine the optimal approach to medical management of a low trauma fracture. You'll be able to describe the clinical efficacy and major long-term complications of anti-resorptive agents, and differentiate between bisphosphonate and denosumab drug holidays. So let's start by introducing the patient. This is a 72-year-old woman, healthy in general. She has well-controlled hypertension. She has hyperlipidemia that is well-controlled. She has a remote history of thyroid cancer that's been, in remission for a long, long time. One day, she trips on the edge of her carpet at home, and she falls, and she sustains a right hip fracture, a right femoral neck fracture. The fracture gets fixed, and then a DEXA scan is obtained, and it shows a T-score at the lumbar spine of -2.1, a T-score at the left hip of -1.7, and a T-score at the left femoral neck of -1.8. Now, as a reminder, osteoporosis, the definition of osteoporosis based on DEXA is when the T-score is -2.5 or lower at any site. So my question to you is, with this information about the patient and with this DEXA scan, do you think she needs treatment for osteoporosis or not? And if you agree that she needs treatment for osteoporosis, just raise your hand. Okay, so I would say about 50% or so of the audience would like to treat her for osteoporosis. And that's actually the correct answer because, as you know, this is the official WHO definition of osteoporosis based on DEXA scan. It goes by the T-score, and if your T-score is -2.5 or lower, that gives you the diagnosis of osteoporosis. But there is another category that goes under the definition of osteoporosis, and this is clinical osteoporosis, which are people with low trauma fracture. And low trauma fracture is a fracture of a major bone that happens from a trauma that is equal to a fall from standing height or less. Okay? So obviously, if I'm standing and I trip and I fall, I should not break a vertebral body. I should not break my hip. If I'm standing on a ladder and fall, I might break those. That's acceptable. If I am flipping my comforter while doing my bed in the morning, I should not, break my shoulder or break a vertebral body. If I cough, I should not have a vertebral fracture. So even though they are not exactly falls, they are less trauma than a fall from a standing height. So people who sustain such a fracture by definition, have clinical osteoporosis regardless of what their bone density shows, even if their T-scores are stone cold normal. So low trauma fractures and osteoporosis, how are those related? Bone strength is what determines our propensity to fracture, and bone strength is actually a composite of bone quantity and bone quality. The DEXA scan can only measure bone quantity. The DEXA is really a measure of how many grams of mineral do you have per centimeter square of bone area. So really, it's just a measure of quantity. It does not give us any insight into the quality of the bone. And as of now, as of this point, there isn't any clinical device, any clinical testing modality that can give us information about quality of bone. There are some research modalities that are being studied, but nothing that we can use in clinic. So back to this slide for a second. So really, even if you have a DEXA that's reasonably good, all that tells you is that your bone quantity is good. But if I fall and break my hip despite a good DEXA, then that's basically telling you that my bone is fragile. My bone has poor quality regardless of the quantity. So following a hip fracture, there is a high risk of increased mortality. So there's, depending on what paper you pick, there is an 8 to 36% increase in mortality. That's double or more that of the age-matched controls of those patients. The greatest risk is in the first 6 to 12 months after the hip fracture. The risk starts coming down after that, but it persists for years. So these patients continue to be at higher risk of mortality for several years after the index hip fracture, although that risk kind of goes down gradually over time. Men are at higher risk of dying after a hip fracture. Older people are at higher risk of dying after a hip fracture. If the patient makes it and doesn't die, only about 2/3 of those patients are gonna go back to home. So 1/3 of the patients who come from home with a hip fracture will end up in an institution. They cannot go back home because that is how disabling that index fracture can be. And less than 50% of all patients with a hip fracture will go back to their pre-fracture level of functioning. So if they were able to run, they might not be able to run again. If they were able to walk, they might need a walker now, and so on and so forth. And then in addition, if they escape all of that with their first fracture, there is a 2 to 5-fold increase in the lifetime risk of another fracture. So if they do okay after the first one, there's a high chance they're gonna have another fracture, and then we start all over again with the risk of mortality and disability. And the risk of recurrent fracture, again, is highest in the first year after the index fracture, but it remains elevated for several years after that. So, a hip fracture is much more than a surgery and something that an orthopedic surgeon will just do a hip replacement or pin and fix. It has very serious long-term implications. Now, the good news, we do have effective drugs that decrease the risk of a fracture recurrence in patients with a prevalent fracture. Now, what I did in this table is I went through all the studies that have been done on osteoporosis medications, and I extracted the portions of those studies where they included patients who already has had a fracture. Okay? So with alendronate, the FIT trial actually had an arm or had a section where people with a prevalent vertebral fracture were randomized to alendronate or placebo, and there was roughly a 50% fracture prevention of a recurrent fracture in those patients, both at the vertebral bodies and the hip. Same goes for risedronate. People who came into the study with an existing vertebral fracture, there was a 60% protection from a subsequent hip fracture. Zoledronic acid is well known for the hip fracture because that's how the major zoledronic acid study was done. It was done on hip fracture patients. And those patients who came into the study with a hip fracture, being treated with zoledronic acid, again, gave them a significant prevention from recurrent fractures. Same goes for the 2 anabolic agents that we have now on the market, teriparatide and abaloparatide. You will see denosumab is not on that list, not because it doesn't work. It actually is a pretty effective drug, but they did not separate their data into patients who had prevalent fractures and patients who did not have prevalent fractures, so I could not extract that data from their study. But in the whole group, when you put them all together, there was a significant fracture prevention. The bad news, even though we know what I just told you about how serious hip fractures are, even though we know we have some good drugs that we can use to prevent a recurrence of a fracture, only less than 25 to 30% of patients with a hip fracture are evaluated and or treated for osteoporosis after a low trauma fracture. When you break them down by sex, only 5% of men with a low trauma fracture get osteoporosis attention, and about 20 to 50% of women with a low trauma fracture receives osteoporosis attention. Now the women, it looks reasonably acceptable, but actually if you dig deeper into that data, most of those women were on osteoporosis therapy before they had their fracture. So really all the medical community is doing is it's putting them back on what they were on when they came in. So actually when you look at how many women who were not on osteoporosis therapy before they sustained their low trauma fracture got diagnosed, how many of those got started on treatment? Only about 5 to 15%. So we're doing a horrible job in catching those patients, those very high-risk patients who arguably are probably higher risk than our average 55-year-old postmenopausal woman who is healthy and who gets a screening DEXA scan and gets started on treatment. These are a much higher risk group, and we're not doing a good job catching them and treating them to prevent recurrences. So where are we failing? As you can see, there have been several studies that have tried to look at this, and these 4 items or 4 points are the places that have been identified by all of those studies, or most of those studies, as being the weak links in our osteoporosis care. Number 1 is suboptimal provider education. When medical and surgical providers were surveyed, just like I asked you at the beginning of this session, if you have a patient with a low trauma fracture who has normal bone density or whose bone density is not low, would you treat them with bisphosphonate? Only about 24% of the surveyed providers felt that these patients need to be treated. Actually, this group did way better than that. And it's because we just haven't done enough good teaching to raise awareness among these providers when they were going through their schooling, they were learning what they need to learn to make sure that they identify a low trauma fracture as an indication of osteoporosis. The second part is, and this is again a major problem, is the lack of ownership among providers. So the patient comes in, a hip fracture patient, typically their pathway is, they break their hip, they're brought into the emergency room, right? So the first provider they see is an emergency room provider. That person stabilizes them, maybe gives them some pain medications, and then hands them off to the orthopedic surgeon. So that person's job, the perception of what their job is just stabilize, pain control, hand off to the proper surgeon. Then the surgeon takes them to the OR, fixes the hip, does the post-op, pain control, mobilization, rehab, etc. And that's it. They consider that their job is done once they have fixed the hip. And then they ship them off to rehab. And then from rehab, the patient probably sees an intermediary, provider, the rehab doctor or the rehab provider for a while until they get discharged back into their community, if they ever go back to their community, and then their primary care provider takes over at that time. Unfortunately, none of these providers really claims ownership, it seems, of the osteoporosis. The ER provider just stabilizes and moves on. The surgeon fixes and moves on. The rehab provider, they just want to get them back into shape and discharged. And then by the time they get to the primary care physician has like 5,000 other things to take care of, because typically those patients are older and they have comorbidities. And they say, well, this is related to the hip fracture. Why doesn't the surgeon take care of it? It's all bone. And actually, unfortunately, there's several surveys that kind of document this lack of ownership. And then when we try to do a better job, then we're not good at talking to each other, right? We don't coordinate. We send like a an EMR referral and it gets, stuck in cyberspace somewhere or whatever. So even when we try to do something, our services are not very well coordinated. And transition of care has ways to go. And then patients themselves do not always realize that what I just had with my hip fracture is actually osteoporosis. And this is serious, and I need to talk to my provider about treating it. In the patient's mind, I had a hip fracture, it got fixed, I'm good to go. So the patient is lacking education, so they don't advocate for themselves as well. So what can we do? I'm going to start by telling you what does not work. So what doesn't work is primary care provider alone. There's been several studies that have tried to reach out to the primary care provider, either in the form of a letter or in a form of a discharge summary, or sending the result of the DEXA scan, of the patient's DEXA scan, along with some society guidelines that say these patients should be treated. And really, these kinds of interventions did not increase the treatment rates of these patients. Patient education alone does not work. So other interventions have tried to talk to the patient. You have osteoporosis, you need to get this treated, this is serious stuff. When you go to your primary care doctor clinic or primary care provider clinic, make sure to talk to them about this. Doesn't work. Rate of treatment do not increase with that intervention. And even consultation of an internist when the patient is hospitalized on the surgical floor did not increase the intervention. So I don't know how you guys have it arranged, but at the university we have a surgical co-management team. Every patient who is admitted to orthopedics gets an internal medicine team to follow them alongside orthopedics to take care of their medical issues. I know this is a model that, we did not create the model. It's, something that's done in many places. Unfortunately, most of our patients who get admitted with a hip fracture, that surgical co-management team does not treat their osteoporosis, which is really what the studies have shown. So when you consult the internist in the hospital to take care of the orthopedic surgeon, orthopedic patient, they're going to worry about their blood sugars and blood pressure and pain and infection and fever and DVT risk. They're not going to treat their osteoporosis. So this stuff doesn't work. It's been tried. What really has been shown over and over and over to work, and what I have at the bottom of this slide is just a sampling of some of the major papers on this, but there's way more than that, is what is called Fracture Liaison Service, or FLS. And what, in its best incarnation, an FLS should consist of a dedicated case manager. Typically, that's a nurse manager. Could be a PA or ARMP too. That person identifies the patients in the hospital who are admitted with a low trauma fracture and does one-on-one patient education with that patient, orders the testing that needs to be done. Do they need a DEXA? Do they need a vitamin D level done? Do they need, whatever it is? Do they need to be checked for hyperparathyroidism, etc. So orders and coordinates all of that. And then there is a physician who typically it could be a primary care provider with interest in osteoporosis, or an endocrinologist or a rheumatologist. These tend to be sort of the biggest categories of physician. But that nurse or that service is attached to this physician, who then captures this patient. So after the case manager has worked with them, ordered the labs, coordinated the follow-up visits, then the physician will initiate treatment for osteoporosis. So this intervention shows, like you see here, more than doubling of the treatment rates. Now still we're not operating at 100%, so it increases treatment rates from 20% to 50%, which is a great result. It's more than doubling, but we're still only helping half of the patients. So it's an improvement, but it's not a complete solution. In addition, it's been shown that this intervention decreases the refracture rate by about 40%, and some studies suggest that it also decreases the mortality, basically with the bisphosphonates therapy afterwards, which kind of makes sense, because if you prevent those patients from having another fracture by treating them with a bisphosphonate, then that mortality associated with the second fracture will go away. Now, there is an increased upfront cost that has been well documented because you have to hire the case manager. You have to dedicate some physician FTE just for this service. You have to organize for all that testing to happen. But every cost analysis study that's been done on this has shown long-term cost savings. So there's a very good long-term cost effectiveness that offsets that initial cost. Okay, so back to the patient now. She was started on alendronate, and 1 year later, she hasn't had any new fractures, and her DEXA numbers have improved. They were not too shabby to start with, but they're better. So T-score at the spine now is minus 1.8. T-score at the femoral neck is minus 1.6, and the hip has gone up from minus 1.7 to minus 1.5. So all is good. The problem is, every time she takes that alendronate pill, every week, she has severe stomach discomfort and pain. So when she presents this to us in clinic, then we talk about, well, okay, let's try something that is injectable so we don't have to expose you to swallowing a bisphosphonate. And your two options are zoledronic acid once every year or denosumab every 6 months. And she chose denosumab. All right, so let's review denosumab a little bit. So denosumab is based, I'll introduce denosumab. Let me talk first, I'm sorry, about rank and rank ligand. So osteoblasts secrete a ligand called rank ligand, and that stands for receptor activator of nuclear factor kappa ligand. And the rank ligand has receptors on the pre-osteoclasts, so on the premature osteoclasts, before they have differentiated into working osteoclasts. The rank ligand binds to its receptor and it activates the differentiation of that pre-osteoclast into a full functioning osteoclast. The osteoclast is the cell that's going to break down the bone. The osteoblast is the cell that's going to come in and fill in the gap, build the bone back up. Okay, so really, and the osteoblast and the osteoclast kind of talk to each other all the time because all of us are supposed to do some turnover of our bone so we can repair our bone and maintain it, flexible and maintain its elasticity. So we always need to be able to break down some of our old bone, damaged bone, and build new bone. And that is one of the main mechanisms by which the builders and the breakers talk to each other. So here comes denosumab. So someone thought, well, since this molecule here is a major activator of the bone breakers, what if we took it out of the formula? So denosumab was created, and it's basically a soluble receptor that when we inject in the patient, it captures those rank ligands when they are still in the circulation, and then they cannot reach their natural receptor on the pre-osteoclast. So we catch them in the circulation, we make them unavailable to the pre-osteoclast. As a result, that premature osteoclast is never going to differentiate into an active osteoclast. So we stop the breakdown of bone, and osteoporosis gets better, and the fracture risks from osteoporosis get better or decrease as a result of treatment with denosumab. So all of that is great. This is just to show you the effectiveness of the drug. The Freedom trial was the first study that took denosumab to the FDA. It was a 3-year study that treated people with either denosumab or placebo. Denosumab is the black line, and then the dotted line is placebo. And then the extension trial was another follow-up 3-year study where everybody was put on denosumab in an open-labeled fashion. So people who were already on denosumab continued it for another 3 years. People who were on placebo during the Freedom study got put on denosumab during the extension study. And basically what this shows is that if you take the medication for up to 6 years, your bone density continues to steadily increase. The total is about 15% improvement in bone density at the spine and about 7.5% improvement at the hip. People who were initially on placebo then started taking denosumab. Their bone responded in a similar way to the people who got denosumab in the first year. So it doesn't matter when you get started on the drug, you're going to have a similar response in terms of increasing bone density. More importantly, we treat not so much to improve bone density, we treat to decrease fractures. The bone density is just a surrogate marker to help us predict the risk of fracture, but it's not, we don't treat numbers, we want to treat outcome. So the outcome with denosumab is, again, very, very good. So there is a significant fracture protection. There is about 68% reduction in vertebral fractures and about 40% reduction in hip fractures with this medication. Well, how does denosumab compare to alendronate? And since I've prepared these slides, there's been some follow-up studies comparing it to zoledronic acid that are very similar. So, you know, alendronate or zoledronic acid, the same idea. It's denosumab versus a bisphosphonate. So this particular study had about 1,000 postmenopausal women who were randomized to either alendronate or denosumab at time 0. And their bone density was tracked, and the women who took denosumab had a greater improvement. It's that top line, the darker line, had a greater improvement in their bone density compared to the women who were randomized to alendronate, both at the spine and at the hip. Now, how about if you use denosumab after a bisphosphonate? This is another study where they had 500 women who had already taken alendronate for 3 years. So they were on alendronate for 3 years, and then they were either kept on alendronate or switched from alendronate to denosumab. And the dotted line are the people who were kept on alendronate. The solid line are people who were switched from alendronate to denosumab. And again, those who got switched to denosumab experienced a greater increase in their bone density compared to the alendronate group. This is not to say that alendronate is not working, because their bone density is still getting better, and we know this drug prevents fractures. All it's saying is that denosumab is even more effective at improving bone density. Now, the caveat of these studies is that none of them were long enough or big enough to look at fractures. So we know that denosumab has an edge over bisphosphonates in terms of increasing bone density by a few more percent points, but we don't know if that delta in bone density is going to translate into more fracture protection compared to the bisphosphonates. Okay. Now, when denosumab came on the market, that was the biggest question that everybody had, because it happened at the time when we were at the height of worrying about bisphosphonates and subtrochanteric fractures and osteonecrosis of the jaw, and this drug came on the market, and everybody was asking, well, is it going to cause subtrochanteric fractures or is it not? But before we talk about that, I want to define subtrochanteric fractures and talk a little bit about bone physiology again. So a subtrochanteric fracture is a fracture that happens anywhere between the lesser trochanter on the femur and the femoral epicondyle. So really, this part of the femur, the fracture can happen anywhere here. This is a subtrochanteric fracture. This is a subtrochanteric fracture. And the subtrochanteric fractures that are related to anti-resorptive agents usually happen with no trauma. Most of the subtrochanteric fractures, up until bisphosphonate issues related to bisphosphonate became a thing, most of the subtrochanteric fractures are observed in accidents. So if you fall and you break your femur, or if you are in a motor vehicle accident and you break your femur, and these tend to be comminuted fractures or helical fractures. The ones that happen in the setting of anti-resorptive therapy, they typically happen with not much trauma. I don't know if any of you have seen any of these patients, but the typical story I've heard is, you know, I was in my car and I was getting out of my car to walk into the restaurant, and all of a sudden, you know, I just couldn't stand and I had this bad pain in my hip or something like this. And basically their femur snapped. So let's review bone physiology briefly here so we understand why this can happen. These are our friendly osteoclasts, which are the bone breakers that I introduced a little bit ago. And then these are the osteoblasts, which are the bone builders. And bone turnover happens in such a way where the osteoclast comes in and it scoops out old bone or bone that is supposed to break. So this is the phase of bone resorption. So it resorbs the bone. It creates what we call resorption pits. And then the osteoblasts then follow them and lay down the new bone matrix. So they lay down the protein matrix of the bone the building blocks of the bone. And then the third step, after these guys are done doing their job, then we start depositing calcium phosphate on top of the bone matrix, on top of this bone matrix here. So we mineralize the bone. So really there's bone breakdown, bone building, bone mineralization, and then we start again, breakdown, building, mineralization. When we have osteoporosis, the osteoclasts are much more active than the osteoblasts. And so as a result, every time we go through a bone resorption cycle, the pit that is created is much deeper than what the osteoblast can keep up with. So then the osteoblast cannot fill it all the way up. So we end up with a bone deficit, with a little bit of bone deficit, but then cycle after cycle after cycle, that deficit accumulates, and we develop osteoporosis. So then here comes the bisphosphonate, or the anti-resorptive agent in general. What these guys do is that they disable the osteoclast by different variable mechanisms. I just described to you the denosumab mechanism. But the point is, the osteoclasts now cannot do what they're supposed to do, so they're not going to be breaking bone anymore. As a result, the osteoblast initially can catch up and fill in some of those gaps that have been created over a period of time. So this is why often when we treat patients for osteoporosis, initially their bone density might get a little bit better. It's that catch-up window. The problem is, remember how I told you the osteoblasts and the osteoclasts talk to each other? One of the major mechanisms being the rank ligand, but there are other cellular mechanisms that go back and forth between them. And as a result of that, if you do something to one side, the same eventually is going to happen on the other side. In this particular case, I'm disabling the osteoclast with an anti-resorptive agent, so what's going to eventually happen is the osteoblast is going to go to sleep as well. Okay? Which is not such a bad thing as far as osteoporosis is concerned, because the end result is still, I'm not breaking bone very fast, so my body has a chance to kind of keep things in control a little bit, as far as the bone loss. So it's still fine as far as the osteoporosis is concerned. But the catch is, this mechanism, osteoclast and osteoblast, one of its major natural functions is to repair bone. So we all get, just as a function of using our skeleton, walking, jumping, doing stairs, falling sometimes, whatever it is that we do with our bodies, our bone is going to develop micro cracks in it, just wear and tear. And the osteoclasts, one of their jobs is to periodically go in and scoop out these damaged areas of the bone, get rid of it, so our body can lay down new healthy bone. What I usually tell the patients, just like your hair gets dry and falls out and a new hair comes out, your skin gets dry, it sloughs, and a new skin surfaces, our bone kind of does that. We slough the old bone and lay down new bone. So when you use an anti-resorptive agent and you put that whole mechanism to sleep, then the potential risk is that we are not repairing the bone. So we're not losing bone to osteoporosis, which is good. The problem is we're accumulating micro damage in our bone and wear and tear that is not being repaired. In addition, when the bone turnover slows down, so when phase 1 and phase 2 are very slow now, there's more time in between to deposit calcium on the bone, which is another reason why our bone density increases when we use bisphosphonates, and it's a good thing as far as bone strength. When you put more calcium on the bone, it's going to be thicker, heavier. The problem is it loses elasticity. So there's only so much calcium that you can put before you lose your bone's ability to bend under the effect of stress. So too much mineralization, hypermineralization can decrease the elasticity. Put the two together, a bone that has lost elasticity and has a bunch of micro cracks in it, at some point it could snap. Okay? Kind of like the stem of an old wine glass. After it's accumulated enough tiny cracks in it, someday you're going to be washing it or bringing your wine glass to your mouth and the stem is going to break. Okay? Now, luckily that doesn't happen too often, but that's what we think happens in those patients who sustain a subtrochanteric fracture. And this is what that fracture looks like. When it happens, it's ugly. It's a through and through fracture. It hurts a lot. And really, you need to pin the femur in order to fix it. And most patients There is, you can see evidence of bone stress before the fracture happens. If you catch it at that point, the cortex gets thickened. There's a little bit of beaking in the cortex. So a good radiologist could tell you if it looks like an impending subtrochanteric fracture. Now, how can we think of doing an X-ray in that patient? Why would I do an X-ray to look for an impending fracture? The reason is here. About 70% of the patients who sustain a subtrochanteric fracture are going to report prodromal pain. And up until, this issue became an issue around 2007, I think, or 2009, really, if a patient with osteoporosis would come to clinic and say, well, my hip has been hurting or my groin has been hurting, a typical answer would have been, well, osteoporosis doesn't hurt. It must be your arthritis. Don't worry about it. You're on treatment. Now, if a patient on an anti-resorptive agent tells me my groin has been hurting or my hip is hurting, I send them for an X-ray to make sure that it doesn't look like this. Because if it looks like this, then there's a high risk it's going to break. Okay? So take that prodromal pain seriously in patients who are on treatment, on long-term treatment with bisphosphonate or any anti-resorptive agent. The risk of this happening, I don't mean to scare you. So I know this looks scary, what I just described in the last 2 slides. The real risk is 1 in 1,000. So very few patients are going to have a subtrochanteric fracture. And this should not be a reason to withhold treatment from a patient who stands to benefit in terms of osteoporosis. But this, you need to really, the take-home message is you really need to carefully select your patients who you're going to treat. If the benefit in terms of preventing an osteoporosis fracture is higher than the risk of sustaining a subtrochanteric fracture, then you go for it. I mean, every time we get in our car, we stand the risk of dying in a car accident, yet we drive our cars all the time because the benefit in general outweighs the risk. So really, it's not meant to scare people of these drugs. It's just to make sure that patients who go on drugs really need to be on drugs. The median time until the onset of these fractures in patients who do sustain a fracture is about 7 years of treatment. So again, it's not something I expect to happen right away when I start treatment. And because of that, that's why we think every so many years of treatment, we try to give the patient a drug holiday. Unfortunately, subtrochanteric fractures have been reported both with bisphosphonates and denosumab. So that first question I started with, when I said, is denosumab going to decrease the risk of subtrochanteric fractures? The answer is no. Okay? It does happen with denosumab. Okay, so what happens after you stop the drug? These studies were done by the same group and were done on patients previously treated with bisphosphonates. And basically what the graph shows is the red line shows all the fractures. Okay? The blue line are the osteoporotic fractures. So the difference between all fractures and osteoporotic fractures is really subtrochanteric fractures. Or most of them are subtrochanteric fractures. And basically, the gist of this graph is that when a patient goes on osteoporosis treatment with a bisphosphonate for the sake of these particular studies, all fractures are going to go down. Osteoporotic fractures obviously are going to go down. And osteoporotic fractures will continue to go down. However, all fractures, after a certain number of years of treatment, will start trending up. And really, that difference here is the subtrochanteric fractures that those patients start experiencing. So after a number of years of treatment, those patients, even though they're still benefiting in terms of femoral neck fracture and vertebral fracture, which are the typical osteoporotic fracture, they're experiencing a higher risk of a subtrochanteric fracture. When you stop the medication, the risk of subtrochanteric fracture actually drops relatively acutely. The problem is after a few years of not treating them, the risk of their osteoporotic fracture will gradually go up. So it's really balancing the risk and benefit, really. It's all about, dancing that dance, playing that game of how much do you stand to benefit versus what risk are you taking. But the point is, if you stop the drug, the risk of subtrochanteric fractures does go down substantially. So then can we stop the drug? And this is bisphosphonate data. It's not denosumab data. The FLEX trial is the best trial to this date, trying to inform us about the idea of a drug holiday. The FLEX trial, basically the way it was designed is, at the beginning, there was the FIT trial, which is the main alendronate study that took it to the FDA. And in that trial, the postmenopausal women were randomized to either take alendronate or take placebo for 5 years. Now, at the end of the 5 years, this is the study that showed alendronate improves bone density and decreases fracture, and all kinds of good things happen. So that's all good. Alendronate became a drug after the end of that study. Now, what they did is they did an extension of it. So for the second phase of the study, they only took the people who had been taking alendronate for 5 years. They eliminated those at high risk of fracture, and they defined that by people who had a hip T-score less than minus 3.5, or people whose bone density was declining while on alendronate during the FIT trial. So the high-risk patients were taken aside, and everybody else was re-randomized to either another 5 years of alendronate or 5 years of placebo. So now what you have is people who took alendronate for 5 years, and then at the end of that, they either continued it for another 5 years or they went on placebo, okay? And this is what the flex showed. So in the FIT trial, people who took alendronate, their bone density at the hip and at the lumbar spine improved. We know that already. Now, when they were re-randomized to either continue alendronate in the red line or go on placebo in the blue line, the people in the placebo group, their bone density did decline over the 5 years that they were on placebo. But interestingly, the decline was rather slow. And even at the end of 5 years, they were still better than their starting point. Okay? So they didn't lose all the gain. It was a gradual, slow drifting down of the bone density. More importantly, what happens to fractures? So fractures, if you look at non-vertebral fractures, there was no increase whether they took alendronate for another 5 years of placebo. There was no increase in non-vertebral fractures. There was increase in clinical vertebral fractures, clinical meaning painful. So these are the fractures where the patient comes to the office and says, my back is hurting. And then we do an x-ray and we find a fracture, okay? So there was an increase in the placebo group in the risk of painful vertebral fractures, but there was no difference. If you did an x-ray on everybody, pain or no pain, there was no difference in morphometric fractures, which basically says the fracture risk itself did not go up, but if you had a fracture, it was more likely to be painful if you were not on bisphosphonate. Okay? But overall, this data is reassuring in that we can take a break from this drug if you are a low enough risk without sustaining major losses, as long as you're watching, as long as you're doing it while monitoring the patient. So back to the patient. Remember how I told you she chose Denosumab when she did not tolerate alendronate? So I put her on Denosumab, and she took it for 4 years, plus 1 year of alendronate, that makes 5 years, right? So I was thinking along the lines of the FLEX trial, 5 years of treatment. I told her, things are looking good, let's take a break now. I'll give you a drug holiday from Denosumab. Everybody is happy, we started a drug holiday, and then she came back 17 months later, and her bone density had dropped significantly. Well, that's not what I just showed you, right? When you stop alendronate, your bone density does not drop that fast. And the reason is that was bisphosphonates. The same does not happen after you discontinue Denosumab, which is really has been sort of one of the hottest topics in the area of osteoporosis for the last couple of years now. So when you stop taking Denosumab, you lose your bone density very fast, okay? This is a study where patients took Denosumab at baseline 6 months, 12 months, 18 months. Remember, it's a drug that you inject every 6 months. So these are the doses. And after the 18 months dose, which would have been here, they were supposed to come back at 24 months and get another dose. And basically, this is when the study stopped. They said, well, we're going to skip the 24 months dose and see what happens. So when you skip a dose, within 6 to 12 months, you're back down to your baseline. If you wait longer, you might even go below your baseline. So all that good result that patients get when they are on Denosumab, it doesn't take much after you stop Denosumab for all of it to go away. What's even more actually, before I get to that slide. And this slide is just to illustrate Denosumab versus alendronate. So this is a study where they put patients on alendronate or Denosumab for 2 years, and then they stopped both drugs. and they followed them for another year to see what happens to their bone density. The patients who were on alendronate, which is the yellow line, when they stopped alendronate, their bone density dwindled down very slowly, ever so slightly, which is what I showed you in the FLEX trial. As expected, a very slow drop. The patients who took denosumab for 2 years, their bone density actually improved better than those who were on alendronate, but when they stopped the drug, it came down to baseline within a year. Boom. They lost everything within 12 months. Okay, so that kind of puts them side by side to show you it's a more effective drug, but it's a drug that doesn't have a legacy on the bone when you stop it. What's more concerning is this report that came up in springish 2017 in JBMR. And basically, this was a report on 25 patients who had been treated. This was a compilation of reports, of case reports. And these patients had been treated with denosumab for varying periods of time. And it shows you here, some of them took it for 3 years, some for 1 year, some for 4 years, et cetera, et cetera. So they took it, and then the medication was discontinued. And what was seen is these patients had several vertebral fractures subsequent to the discontinuation of denosumab that occurred as early as 2 months after missing a dose. So very quickly, not only do we lose bone density very quickly, which several studies have demonstrated, we actually might experience a rebound increase in the frequency of vertebral fractures after we stopped denosumab. This really got a lot of attention and got people really thinking and rethinking denosumab drug holidays. So why does this happen, Why do we have that, kind of drastic increase in the risk of vertebral fractures? It's exactly because of the way denosumab works. Remember how I told you it's a receptor, it's a soluble receptor that's meant to capture the rank ligand in the circulation and not allow it to reach and interact with its natural receptor on the pre-osteoclast. Well, when you inhibit a ligand from reaching its receptor, then the receptor is going to upregulate. So really, these pre-osteoclasts that are deprived from their ligand, that receptor is going to upregulate. So when I stop denosumab, all of a sudden, those rank ligands that are now freed up, they're not being captured in the blood anymore, they can reach their target. They have a lot of target to work on, right? The target is avidly sitting there waiting for them. So actually what we get is a hyper differentiation and a more than normal rebound increase in differentiation of pre-osteoclasts. And this has been shown in this study that looked at what happens to bone turnover markers. So CTX is a marker that we can measure, and it gives us an idea of bone breakdown, of bone resorption. And P1NP is a marker that gives us an idea of bone building or bone formation. And again, this is the same study where I showed you the change in bone density. So patients received denosumab at time 0, at 6 months, at 12 months, at 18 months, and then at 24 months, they did not get denosumab. And look what happened to their bone turnover markers, whether we're looking on the resorption side or on the formation side. There was a drastic, rapid increase that is double their baseline. This is where they started before the medication. And this is where their bone turnover landed within a year of stopping the medication. So their bone turnover didn't just go back to where it was at baseline. It actually doubled from baseline. Now, eventually, it comes back down because things settle down. The biologic system is going to settle down. The receptor is not going to stay upregulated. But that takes a while. And during this year, when the bone resorption and the bone formation and the bone turnover is just going crazy, coming back with a vengeance, this is when we lose all the bone density and the fracture risk increases. All right, so can we take a denosumab holiday? The answer is no, we can't. Unfortunately, if you put someone on denosumab to treat their osteoporosis, it's not going to work the way alendronate works. You cannot treat them for 4 or 5 years or whatever number of years and then just stop it because they will lose the bone density. So then the next logical question is, well, what if we treated them with denosumab for whatever number of years we want, depending on their clinical situation, But then instead of stopping denosumab, we bridged it with a bisphosphonate, and then we started a drug holiday. So basically denosumab for a number of years, then a bisphosphonate for a number of years, and then start a drug holiday. Is that gonna work? Okay, so this is really logically, theoretically, and I'll show you a little bit of the kind of the basic science thinking behind it, it might work. But the first question is, well, do we have any data that supports this practice? Is alendronate even, gonna hold the bone density after denosumab? And the answer comes from this study. This is a small study that was done not to look at this particular question. Actually, the title of the study is Denosumab versus alendronate patient satisfaction. So really, it's a study that randomized people to alendronate or denosumab for a year and then crossed them. So the ones who were on denosumab were given alendronate, the alendronate group was given denosumab, and the idea of the study was to demonstrate that patients who take denosumab are happier than the patients who take alendronate. Because it's easier, you only take it once a month, you don't have to worry about sitting upright and remembering to take it every week, et cetera, et cetera. And actually, it turns out that patients who did take denosumab were happier, were more satisfied than the alendronate patients. But the byproduct of that study is that it gave us the answer to the question I just posed. If you treat someone with denosumab for some time, and then you switch them over to alendronate, they don't lose bone density. The alendronate preserves the bone density that they accrued while on denosumab. And that is, at the time, people were not paying attention to this, but now in retrospect, it's kind of a reassuring piece to us, is that if I have a patient on denosumab and I don't want them on denosumab anymore, I know that I can switch them to a bisphosphonate and they're not gonna lose bone density. Okay? So that answers the first piece, is that you can transition from denosumab to a bisphosphonate and maintain the bone density. Now, why would this work? Because bisphosphonates work on the mature osteoclast. So I already told you that denosumab works on the pre-osteoclast, inhibiting the differentiation of the premature osteoclast into a mature osteoclast. So denosumab stops maturation, okay? Bisphosphonates actually take the mature osteoclast and does all kinds of things to it so it doesn't work, okay, including apoptosis, including killing it. So when we release the pre-osteoclast, when we stop denosumab and we release the differentiation, but then we use a bisphosphonate to capture it after it's differentiated. So we let it happen and then we capture it at the end and disable or damage it. It seems like it works. Okay, we still have a lot of unanswered questions. Can we eventually stop the bisphosphonate? We don't know. I'll come back to a small observation, which is how I base my practice, but we don't have any data on that. If we can stop the bisphosphonate, how many years do we have? We call this now consolidation therapy after denosumab. So we do denosumab, then we consolidate with a bisphosphonate. The idea is to stop it eventually. But how many years of consolidation do I have to do? We still don't know. People are looking at that question now, but the results are not out. Does the bone density stay reasonably stable after I stop the consolidation therapy? Again, we don't know. No one has published any result on that yet. Does that prevent rebound fracture? We don't know. We haven't reached that point yet. People are still doing the research. So theoretically, it seems like it makes sense, but there's a lot of unknowns that we are waiting to be clarified with research that is currently being conducted on this topic. So back to my patient. I put her back on anti-resorptive therapy, this time in the form of zoledronic acid, and my plan is to give her 2 years of zoledronic acid and then try for a drug holiday again. Now, you might ask me, why did you pick 2 years when you don't have any research, any of these studies, that are being conducted to inform you? And I picked 2 years because of this. Because of this study. See, this is the study that showed the increase in bone turnover after you stop denosumab. If you look at 2 years from discontinuation, then the bone turnover is almost back to baseline. So it seems like that hyperactivation of the bone turnover and the hyperactivation of the osteoclasts is settling down about 2 years later. We're back to baseline. So my reasoning is, if we're back to baseline and we don't have that upregulation of the rank receptors on the osteoclast, and I don't have that hyperactivation of osteoclasts, maybe that's a good time to try for another drug holiday. But I would have bridged this crazy area, this crazy period of time with a bisphosphonate. Okay? That's my theory. Nothing to back it up yet. But that's generally what I'm doing with those patients, unless by then some new data informs me otherwise. Okay, so take-home points. Low trauma fracture means osteoporosis. It requires multidisciplinary approaches. We need to play well together. We're all responsible for the patient at the end of the day. We all own the patient. We have some great drugs that are available and that work. We just need to prescribe them. Subtrochanteric fractures, it's a very small risk, but it applies to all anti-resorptives, including denosumab. The risk decreases with a drug holiday. Drug holidays are possible with bisphosphonates in low-risk patients, but drug holidays with denosumab are not feasible without consolidation therapy. And that whole area is still a big question mark at this point. So with that, I'll stop and take your questions.
Okay. Thank you. Good talk. And so I have a question about the time that's optimal to start either bisphosphonates or denosumab after a fracture. Just, is there anything as far as 2 weeks, 4 weeks, 6 weeks, anything to prevent non-unions, et cetera? Is there any data out there on healing? And then I've got another question.
Right. So what is a good time to start anti-resorptive therapy after a fracture has occurred? The main concern is starting an anti-resorptive therapy too soon after a fracture going to impair healing, because you make callus after the fracture and you need to be able to resorb the callus to remodel the bone. So would putting an anti-resorptive agent on top of all of that at that time going to impair the callus resorption? There's been 2 studies that have looked at that. One is, there's been some animal studies, but I'll focus on the human studies. 2 studies are out there. One is a retrospective study that looked at people who got joint replacement surgeries, who were either on bisphosphonates or not on bisphosphonates. And it showed that the patients who got joint replacement surgery while on a bisphosphonate had an increase in time to healing. I'm trying to remember the orthopedic term that they use. They took a little bit longer for the fracture to completely heal, but that time was like a matter of days. So it was statistically significant, but it was, I don't remember the exact number of days, but something like 5 days or 7 days or something like this. So really, in the big scheme of things, it's not like they never healed. It just took them like about a week longer or so. Now, the more important data comes from the Horizon trial, which is the zoledronic acid main study. Basically, the way the study was designed, people got admitted with a hip fracture, acutely with a hip fracture. And those patients were randomized to zoledronic acid or placebo after their hip fracture. Some of them were randomized immediately at the time of admission. Some of them, it took a few weeks. So the randomization happened anywhere between time 0 and times 3 months. When they went back, and everybody as a group benefited, and there was no delayed healing of their hips. A hip fracture is typically repaired surgically more often than not. And then they went back and they sub-stratified the group into, if we started treatment in the first month or the second month or the third month, and it turns out it doesn't matter how close to the fracture and the surgery that the treatment was initiated, healing was not impaired. So, to me, that's very reassuring results. So what do I do in practice? If I know that the patient is not going to get lost to follow up, I don't take chances. I wait until the fracture has healed, and then I get them started on treatment, because really, what's another few weeks? But if I'm worried that this patient comes from far away in the state, they might not make it back to clinic, it's going to be an issue to bring them back, whatever, then I'd rather treat them right away. At least I know that they got the drug in them.
And then one other question for the subtrochanteric fracture risk. If you have somebody that has completed their 5 years of, say, zoledronic acid, and then they're still declining and you want to shift them over like to Prolia, are we we're essentially not taking a drug holiday then whatsoever. And so is it better to do something like Forteo if you can get it covered, or are they still at increased risk of the, despite
Yes, so
changing?
switching from a bisphosphonate to denosumab does not decrease the risk of subtrochanteric fractures because you're still suppressing the bone turnover, and it's that suppression of the bone turnover that's believed to lead to the subtrochanteric fracture. So the question is then, should I do an anabolic agent instead? Yes, depending on how high risk the patient is, you might want to consider an anabolic agent. Now the caveat though is if their bone density, if they are on a bisphosphonate and their bone density is declining significantly, then basically their bone turnover is not suppressed. So they might not be at the same risk of subtrochanteric fractures as your average patient because you haven't suppressed their bone turnover. So maybe you don't need to worry as much about prolonging therapy. I mean, that gets us into a whole other discussion of what is drug failure and what have you, but that might be a slightly different patient population.
Okay, thank you.
Yes.
First, I have a comment. I'm a general surgeon, so a lot of this was outside of what I do, but I loved the talk.
Thank you.
I'm really interested in why physicians, smart people, don't do the right thing when presented with evidence. And a lot of times it falls into logical fallacies. And I think I've created a logical fallacy for this one that fits a lot of my life. And that's the fallacy that I call divination fallacy, that I can look at you and figure out what it is that you need through some supernatural process or some, process of you as my patient. I can tell that you don't need any platelet therapy or whatever. And I just want to educate students or whatever that no, you can't. You really do have to learn to be a scientist and go through the data and figure that stuff out, because there's nothing about Dr. Jordison that lets me know that he's going to benefit from whatever. I've really got to be a scientist. But back to this. Your patients that are at high risk for that second fracture, are there things about their lifestyle or their medication profile or whatever that's buried inside that high risk? You didn't really talk about activity after their fracture repair and how that impacts things.
So the question is, those patients with hip fracture are at high risk for a recurrent hip fracture, and is there something that can be fixed, lifestyle related or what have you, that accounts for the high risk? The studies that have tried to, and granted it's all retrospective study and the study is as good as the data that goes into it, but when people try to stratify by risk factors and try to identify a subgroup of patients who might be at higher risk, some of the patients at high risk obviously are patients with dementia, patients with a stroke because they're more likely to fall, patients with alcohol abuse, but even your average active, healthy patients still are at high risk. So there is a big chunk of the increased risk that there's nothing in the patient's health that accounts for it. And it's believed to be probably related to an increase in the recurrent fall risk. When you break your hip, there's a certain amount of deconditioning. You start using your legs in a funny way. You don't put as much weight on it. You protect it. So maybe it's some subtle alterations in gait or what have you that increase the risk of that patient falling again.
So it supports my fallacy thought.
Yes.
Two questions. First, what recommendations do you have for screening men for osteoporosis, just screening? And then secondly, denosumab, it's given every 6 months in the osteoporosis setting, but in oncology, it's given more frequently.
Every 4 weeks.
Yeah. Are there studies looking? Are studies looking at just bone density in oncology patients, getting it every 4 weeks? Is there a more rapid increase in bone density? What happens in that setting?
So the first part of the question, screening recommendations for men. For the healthy average risk man, the risk of fracture increases after the age of 70. So it's recommended to screen all men at the age of 70 to do a bone density test. Women, the risk increases at the age of 65, so it's recommended to screen women starting at the age of 65, not at menopause, by the way. Now, if you have a man or a woman who have high risk, other risk factors, including, say, alcoholic or heavy steroid use or heavy smoking, you might want to choose to screen them sooner than the magic ages of 65 or 70, because those patients, the presence of those risk factors might increase their risk. And actually, if you go on FRAX, which is available online, you can calculate the patient's risk of fracture based on their BMI without a DEXA. And you could use that to guide you as to whether you want to get a DEXA or not in those patients who are still younger than 65 or younger than 70. The second part of the question is, what happens to the bone density of oncology patients who take these drugs every 4 weeks or so? I cannot claim I've read all of that literature. The literature I'm familiar with hasn't really looked at bone density because these patients are being treated because of bone cancer and bone metastases. So they're either multiple myeloma patients or patients with prostate cancer or something like this with bone mets. So the literature I'm familiar with, and I don't know all that literature, hasn't really studied bone density effects carefully. How do we get to 6 months? It's actually effective for 6 months. Let's see if I can go back. Yes, the effect lasts for 6 months, and you kind of get a sense of it. That's how they determine the 6 months, or part of the preclinical studies. So you got a dose of denosumab here. Okay, your bone turnover drops by something like 90%. So it really acutely suppresses your bone turnover. If you track the bone turnover at the 6 months mark, you'd see a little bit of an increase, like a 5% increase or so. And then you shoot them again here, and it comes back down, and then it goes up. So really, there's a little bit of revival in bone turnover during that 6 months, but it's only of a few percent points. So that's why that's one of the reasons why it's every 6 months, and it does work when you dose it that way. It's not enough wake up of bone turnover to cause a problem. All right, well, thank you. And thanks for all the people who are not in this area who stuck with me through this talk.